first ticket. The second question about vomiting and abdominal pain. Not we surgeons, that answer of the question, suspect gastrointestinal bleeding. And here you should answer. But I want you to see some situations that we can have in practice, because it's quite often when you see, for example, the vomiting first, and then you know that there is a bleeding. And first of all, according to ABCDE approach, you should start with the step A. And when you see vomiting, you should be sure that this patient couldn't have the aspiration, because the aspiration will lead to a huge problem to this patient, even without any bleeding. So when you see the patient with vomiting and he lay on the bed or on the floor, you should move his head to the side and control the vomiting goes outside and he is not aspirated. It's very important. So, and then when you see the bleeding, you go to the step B, the patient breathes in, and if the patient breathes quite, not normal, but adequate, and provide the oxygenation, he is, for example, has tachypnoea, but the oxygenation you see is not so bad. You go to the step C, and in accordance to bleeding, if there is external bleeding and you can see the wound, you should stop it or try to apply the tourniquet. If there is a bleeding from some vessel, external bleeding, for example, broken leg or something else. If there's bleeding from the mouth and you don't know the place of bleeding, you should call for the surgeons. And while you wait in the surgeons with endoscopic equipment, you should insert the intravenous cannula and start the fluid infusion to compensate the bleeding. If you see the black color of the blood and vomiting mass, you can say exactly that this is gastrointestinal bleeding. The same you will see from the rectal investigation. When you see the black color, real black color, not dark brown. Once you see this signs, you will you will not this forever, because it's a real dark black color of the of the blood. So here the question is about the hemorrhagic shock. And first of all, you start with breathing, airways, then breathing, and you should apply patient to the comfortable position to not let him aspirate. And then you deal with bleeding. You provide infusion and you call for surgeons.
Professor, what diagnostic method should we use? Should we use endoscopy or laparotomy?
In the gut?
Yes.
In your answer, we wait only that you will call for the endoscopic surgeons. And it could be argon laser, or they even use electrocoagulation. So this is a question of for surgeons. Could be, and if we have only 5 minutes for each student, you shouldn't provide such a additional information, you should say that you will call for endoscopic surgery. And if you know variants, you can say it quickly for argon laser or electrocoagulation or injection of adrenaline in the place of ulcer, if it would be the Forest A, the classification of the ulcer bleeding, if you know. So your goal is to not let the patient die. So you should provide the airways assessment. You should maintain the breathing. If the patient doesn't breathe at all, you should provide the intubation of the trachea. I'm sorry, guys, 1 second. So, sorry. And after that, you provide infusion. You should maintain the airways, the breathing, and the circulation of the blood to not let the hypoperfusion to exist. So, and you will wait for the bleeding stop, because without this, you will lose all the blood. So it would be not
Professor, what will be the diagnosis? Will it be GI bleeding or not?
In the first question, yes. Here we suspect the gastrointestinal bleeding.
Okay, thank you.
But the abdominal pain is a very rare symptom. You should know about this in your practical life. You will see that during the gastrointestinal bleeding, it's quite rare.
Okay, thank you.
You should know. Exam is only 5 minutes for you, and you will work with the doctors for whole your life. So you will see such patient, I think, whatever profession you choose, a physician or the surgeon or intensivist, you will see the gastrointestinal bleeding. It's quite often. So it would be your own experience. So what else? What else is difficult?
Professor, the last variant 23, the second question.
The last second question. Person work into your health post with low blood pressure. This is ACG, abnormalities, electrocardiogram. This is a mistake here. What should you do? Here we suspect the myocardial infarction. And as we see low blood pressure already, we can suggest that there is a myocardial infarction, a huge myocardial infarction. And you should first understand the step A, that the patient has free airways, then that he can breathe. It would be the tachypnoea, but he will provide the oxygenation. And then you go to the step C, and you'll see, you understand that the low blood pressure and the tachycardia you will see here. You can imagine it through this sentence. And on the next step, you assess the electrocardiogram and you see the abnormalities. Which abnormalities? Here is not written, but you can suggest that this is a myocardial infarction. And as you will read carefully, you will see that when the person walks into your health post, the patient walks by himself, by feet. This is mean that there is not a shock situation was. It could become the shock after the few minutes after the symptoms onset. Here we want to discuss the acute myocardial infarction. And what should you do? you should do ABCDE. On the step C, where you find the low blood pressure and cardiogram abnormalities, you should provide the nitroglycerin spray under the tongue and the aspirin with the clopidogrel orally. And you insert the intravenous cannula. If there is a signs of shock, the pale skin, the prolonged capillary refill time symptom, and blood pressure below 80 systolic, you can start the infusion of inotropes. And as quick as possible, you should transport this patient to the angiography laboratory for the coronary angiography and stenting of the coronary artery without infusion. Or you can apply a small amount of infusion. But this point is not in guidelines of the acute myocardial infarction. So here you should provide the angiography with stenting as quick as possible. If you see the ST segment elevation on the ECG, here is not say about this, but if there is ST segment elevation more than 2 millimeters, you can take this patient to the angiography without any other blood analysis. You shouldn't wait for troponin, because the analysis for troponin takes half an hour and it's quite a long time. You remember that we have only 2 hours to predict the myocardial cell death. So in this ST segment elevation, we should provide angiography as quick as possible. If there is no ST segment elevation or depression or other signs of myocardial infarction, we can provide the maintenance of the blood pressure with inotropes and analgesia if the patient has the chest pain, and we will wait for the troponin. And then there is a GRACE scale, if you remember, there is in our cardio shock presentation. If there is no strong signs of myocardial infarction, we should assess for the first hours, assess the troponin level twice, and other points in blood analysis. So to decide if there is a need to provide the angiography or not in the nearest hours. Nevertheless, in all cases, we should provide the angiography, but it could be not immediately. But if you see this ST segment elevation and you suspect the myocardial infarction, you should immediately go to the angiography. So here it would be enough. The nitroglycerin, aspirin, clopidogrel, or ticagrelor, or other variants of such drugs, as they are written in the presentation and in guidelines on the acute myocardial infarction, and inotropes, if it needed, if you cannot maintain the blood pressure, and the stenting of coronary artery. And after the stenting, you will see that everything gets better. First 2 hours, you will see the arrhythmia. It could be after the recanalization of coronary artery, and it's normal, but we should pay all attention to this patient in the ICU for the first hours after the stenting.
Professor, can you switch to variant 5, second question?
Second.
Variant 5. Variant 5, yeah. Yeah, the distributive shock. So there are many types of distributive shock. How should we answer this question?
You should answer all the types of distributive shock, as you know. You should count them first.
Anaphylactic shock, septic.
And
Neurogenic.
We should answer all these.
You should answer what types of distributive shock do you know?
I would go for anaphylactic shock.
There is a separate question. So here you should say what common in these shocks, and the common features is the pathophysiology. The different triggers, but the same pathophysiology. The trigger in anaphylactic shock is some allergic agent. In septic shock, there is a bacteria as a trigger of shock situation, and in neuronal shock. So you should say about the pathophysiology here, about the enlarged vessels and leaking from the vessels to the interstitial tissue. And that's all. And if you will have time, you'd better prepare the few words about the treatment. Because the anaphylactic shock, this is adrenaline, 0.5 milliliter intramuscular, each 5 to 15 minutes. In a septic shock, there is antibiotics, norepinephrine, and fluid infusion. In neuronal shock, there is also the norepinephrine and fluid infusion. And that's it.
Hey, Professor, question 17, the second part about Ben.
17. They have patient with burns. You know, I discussed it with my chief. We decided to exclude this question because it's really difficult question.
Good.
Not a few words about, and we had no such class about the burns because it's really difficult, and we didn't discuss it. So it wouldn't be a question about the burns.
Okay. Thank you.
But we will compensate it, I think, next year, next time when you will have our course. We'll discuss it.
Professor, so we won't get the question 17.
You will
Yes. 17 is out.
the disability. We will discuss
Okay.
step disability, but the question about burns disappeared.
Okay.
I'll give you only, in my groups, I'll give you for, I think, one question. If you will answer one question well, so it would be all your exam. If you answer not very well, you'll get the second question. But
Oh,
it would be the clinical situation.
okay.
I don't
Uh,
know.
Professor, please tell the other professor to do the same because we have not had classes with him and we don't know how he will be.
So I think Professor Kologorsky will ask you about ABCDE approach for all of you.
Oh, okay.
So
I think should be fair. All students one question.
this is the main part. The clinical situations are there's a lot of clinical situations, and in your practice you'll have different variants. And now it's even it's not maybe not fair, but it's not all. It's only a small part of the clinical situations. So it's better if you remember the ABCDE approach because we can apply it in all situations. But we can spend only a few seconds. If you see that the patient is breathing, the step A and B goes for the 30 seconds, and then you start with the circulation. If there is some problems with breathing or with the heart, you see the heart attack. You should be ensure that the patient can breathe and have no the airways obstruction, and you can check it for a second. But you should remember all the steps one by one.
Excuse me, teacher. Concerning the exam, any idea when at what time the exam will be, and is it on Zoom?
No, it's not possible on Zoom. It would be on your portal, and in your cabinets you have, I think, already have the link to the enter to the conference. And
I think we still don't have it.
No, you have it.
We have
Check.
it. We have it.
And there is exact time for each group. Even there is 6 to 8 students for half an hour, and you have your own time. You will be in small groups, and will enter, and Professor Kologorsky will enter your conference at your time, one by one.
Excuse me,
okay.
Professor. Can we do question 22, the second part?
What question?
22.
22. Unconscious patients with unequal pupils, weakness on the side of the body. This is a stroke.
Mhm.
And you should.
So should we give Urapidil because we can think of increased blood pressure?
There is nothing to say about blood pressure, but the diagnosis you will see from the first seconds when you look on this patient. You can suspect the stroke. And you should apply a BCD approach here too. You should ensure that areas are free, the patient can breathe, and you should touch their neck for the pulse and ensure that it's some appropriate blood pressure, and you should do it for the first minutes, and then you should go to the CT scan.
But we should give glucose, right? Since the patient is unconscious, we can give them glucose solution.
If he is unconscious,
Yeah, we can give.
the same, provided if he can breathe normally, but without conscious. He is unconscious. It could be the huge stroke because unequal pupils, and you can see the different, the asymmetry of the body. Maybe this is some controversial things. If the patient is unconscious, how can you see the weakness?
Exactly.
Outside of the body. It's here I think we want to discuss that maybe you can see some abnormalities, maybe the hypertonus on arms or hyperextensor on the leg, on feet. Something, these signs of the stroke from one side of the body, and the normal position of the head, of the hand and leg from the another side of the body. And this is the symptoms of the stroke too. So even the patient is unconscious or not, you should be sure that his areas are free and he can breathe. And there is some blood pressure, some appropriate blood pressure, and maybe tachycardia, maybe hypertension. Here you can find the hypertension quite often. After you understand this.
Professor, hypertonus situation doesn't mean it's a weakness. It means an abnormality, but it's not a weakness, right?
Yeah, you're right. But this is unconscious, and weakness from the one side, as we said, this is a controversial things. You can find only unconscious patient with a hypertonus or weakness from the one side. You can see, you can figure out it. You check the reflexes.
Mm-hmm.
But you see asymmetry of the face.
Yes.
Yeah, it could be weakness on the lips or eyes.
Like facial palsy.
Yeah. But not on the body. But when you check the reflexes, you will find this maybe weakness of some reflexes from the one side of the body.
Mm-hmm. And Professor, can you please give a view on variant number 15, question number 2.
Okay, you should say about the CT scan to differentiate hemorrhage or ischemic stroke, and this is very important. Or this the treatment depends on this results.
Professor, I just have a question. If there is a question about shock, like example cardiogenic or anaphylactic, so should we answer the pathophysiology or should we answer the diagnosis and the treatment?
You should say a few words about the pathophysiology. For example, cardiogenic shock, low cardiac output, low blood pressure, peripheral hypoperfusion.
Okay.
And then you should say a couple of words about treatment. What to do? If cardiogenic shock, myocardial infarction, angiography, stenting, inotropes, and something else. If there is a septic shock, then norepinephrine, fluid infusion. So, in anaphylactic shock, you should stop the medicine or some allergenic agent that trigger this situation, and rise the legs, and adrenaline, infusion, and corticosteroids. In the 16.
No, Professor, 15. 15.
Abnormal sound from airways, stridor, snoring, and gargling. When you see or hear stridor, you can suspect some airway obstruction. And here, first of all, we should look at the patient, and if it's possible, we can apply the Heimlich maneuver. And if there is something on the throat, we can try to get it out. And that's it. You should describe how to do Heimlich.
Can we do 16 and 21 also?
16. What is ABCD approach? You know?
No. The second one, of course.
You found out that a patient's mental status changed. What should you do? This question is about, you see that this is found out that the patient's mental status are changed, and we suspect the hypoglycemia here, because only in hypoglycemia the mental status changed suddenly and quickly. And here you should answer about hypoglycemia, like most frequent occurs of mental status changes. You see that the patient is not unconsciousness, but the mental status changed. It could be stroke as well, because it's happened suddenly also. And you should divide this diagnosis. You can figure out if there is a hypoglycemia only after the blood glucose test from the peripheral blood. The glucometer it takes 30 seconds for the glucometer. If there is a hypoglycemia, you should deal with it and provide the glucose infusion. If there is a normal range of glucose in blood, this is more likely to be a stroke. So you should deal with a stroke and to go.
Can it be include the seizure?
What? One more.
Seizures.
The mental status changes can be included, the seizures as well, or not?
Yeah, it can be. But if you have time to discuss it on the exam. So, the external bleeding wound, you should apply the tourniquet. If there is a bleeding wound from the carotid artery, you shouldn't apply the tourniquet. You should push this artery with your fingers. Do not allow the bleeding to continue. And wait for surgeons.
Professor,
Professor, can we do 14 question 2?
What question?
Variant 14. Question
2. Can we do 21 first? I asked for 21. Second question.
You have a patient with altered mental status and head trauma. And the same altered mental status, but the head trauma and the hypoglycemia is unlikely here. And here we suspect not the stroke, but the head trauma means that you should take this patient to the CT scan to find out maybe hemorrhage, intracranial hemorrhage.
Concussion, can it be?
Person who walks with chest pain and low blood pressure, it's about acute myocardial infarction. You should make the differential diagnosis with pneumothorax here, because it could be with pain and low blood pressure. So, what else? Septic shock.
Yes, Professor. This variant 8. How is shock diagnosed?
How shock diagnosed? You should say about, first of all, the clinical signs. According to ABCD approach, you will see that the patient, the breathing patterns change. The airways would be free. The breathing pattern is changed. It could be bradypnoea or tachypnoea. And on the step C, you will see the low blood pressure and the signs of low cardiac output of peripheral hypoperfusion. And this is a common thing about any cause of shock. Because of course, if the patient admitted from the street, you don't know the previous history, you only will see that he is pale, the capillary fill time symptom is very long, more than 2 seconds, and you will see that maybe murmur skin and the cold extremities, and the blood pressure would be low. It would be tachycardia. And the next step, you should make the differential diagnosis. If there is a shock or myocardial infarction, you should apply the ECG, and you will understand about the infarction. Or there is an anaphylactic shock, you will see the dots, red dots on the skin, and it will give you the answer. And what else?
Do we do any investigation apart from ECG and like checking the vital signs? Like, should we check serum lactate?
Yeah, you first you provide the ECG, and if there is a myocardial infarction, you will understand it quickly, and it would be cardiogenic shock. Because shock is the impairment oxygenation of the tissues for any reason. So if you find the myocardial infarction signs, this means that this is cardiogenic shock. If you find the ECG is quite normal, but without any myocardial infarction sign, you will go further and try to find out if there is any another reasons for septic shock, for another, for example, some previous surgery, it could be, or appendicitis, or this patient could be from the other hospital after some other operations, or this is some, you can take the dedimer, and you will understand about, if it's high, you'll understand about the pulmonary emboli. And then next in ICU, this patient is already in ICU. If there is shock, we will provide mechanical ventilation in most cases. And we will apply the inotropes or vasopressors and fluid infusion almost in every shock patient. And simultaneously, we try to find the reason of this situation. We have echocardiography. We apply it to this patient, and we will understand about the pulmonary emboli. If the patient is in shock in cause of pulmonary emboli, we will see the abnormalities of the right ventricle, and even if there is a huge emboli, we will see it on the echocardiography. So after that, we suspect the diagnosis, and we'll go to the pulmonary angiography, and to prove this diagnosis, and we will start the alteplase as quick as possible.
Excuse me, teacher. I don't have a link to the exam.
What your group number?
Group 77. Allah Abdul Nasser. I will write my name.
Please write me your name. I will check our.
Where is it?
Because I have the links to your exam already. I'll check you.
Yeah, because I didn't get it on my site while all my colleagues have it already.
Mm-hmm. Okay, I'll check your name.
Okay, thanks.
Mm-hmm. So,
Professor, in acute myocardial infarction, what is the point of giving magnesium sulfate and insulin to a patient?
Myocardial infarction, first of all, after you understand the diagnosis, in treatment, you should if there is a pain, you start with morphine.
We cannot hear you, Professor.
I didn't hear the last words.
We couldn't hear you for a little bit, but now it's okay, Professor.
Okay.
Yeah.
So, about the myocardial infarction, you should say only the main points, that there is indication for angiography and stenting, and the nitroglycerin, aspirin, clopidogrel, and analgesia with morphine.
Okay, no, I'm asking you, what is the point of giving them magnesium sulfate and insulin?
What do you
Like magnesium sulfate
Magnesium.
and insulin.
And some doctors can apply the magnesium in the aim to decrease the blood pressure. There is no guideline, there is no randomized trial according to beneficial use of magnesium.
I think sometimes they give magnesium because magnesium is allosteric inhibitor of calcium. It's more potent in the receptors, so it exchanges the calcium and decreases the blood pressure, and even even dilate the arteries, coronary arteries. Probably, maybe that's why.
Such a point of view, and there is some pathophysiology in this treatment, but it's not obligatory, and there is no randomized trial that prove this treatment. So we can do this. This is not prohibited, and it could help, but it shouldn't be the first treatment. You should act according to guidelines.
Professor, can you go to variant 14?
Con aire.
Oh. We discussed the shock diagnosed.
Variant 14.
Yes. First of all, you should diagnose. You check the air rate, the breathing. If there is need to intubate this patient and to start mechanical. So, and the next, you go to the circulation, you see the low blood and the signs of peripheral hypoperfusion, and you the next step of the circulation, the ECG. If there is myocardial infarction, you go to the angiography and stenting. If there is no signs of myocardial infarction, you go further. And except myocardial infarction, you could start fluid and norepinephrine. And you suggest some sepsis. You, by the way, your nurse or your helper take the blood analysis, and you will see the dedimer or the lactate that proves that there is a shock condition. And if there is a high dedimer, it could be the pulmonary emboly. You can provide the echocardiography. And in the ICU, we have the X-ray, the mobile X-ray. We can apply it right in the intensive care department. So after the X-ray, we can see on the screen of the device the photo of the chest, and we can understand if there is a signs of pneumothorax or hydrothorax. If we didn't catch these signs before on the step A and B, because the signs of pneumothorax understand from the step A and B, and it would be the diagnosis. If the AB is quite normal, we move to C. And after first 3 steps, we can understand already what is the diagnosis and what to do the next. And if there is pulmonary emboly, we will go to step D and provide the pulmonary angiography and the treatment according to our diagnosis. If there is a sepsis and septic shock, after we suspect this, we should treat the urgent situation, improve the blood pressure, and maybe start the mechanical ventilation. And then we should call for surgeons, because we should find the place where could be the bacteria. If it's possible, it would be good to provide the CT scan of the body, find some place of the bacteria, and surgeons could help in it. So, what are the difficult questions?
Variant 14.
14?
Yeah.
14.
Second question.
Yeah. I see that you are quite confident in first questions in each ticket, and it's good. The person wanting to process abnormal sounds from airways and complaints with short breath. It could be first of all, it could be some airways obstruction with the food. There is nothing written about the previous history of the patient, and we can suspect that it could be after the breakfast. So you should apply the Heimlich maneuver. And another point that you can notice the short breath, complaint on the short breath, could be the pneumothorax or pulmonary emboly. But these two diagnoses, both of them, are not connected with the abnormal sounds. The abnormal sounds and short breath could be in anaphylactic reaction, could be together. And if there is an anaphylactic reaction, you can find the previous history quite quickly. Maybe this patient goes from the nurse, where he gets some pills or injection, and it would be the trigger of anaphylactic reaction. So here you should make the differential diagnosis between the anaphylactic reaction and some obstruction, areas obstruction with some food or something like this.
Professor, can it be pleural effusion or like chronic case of COPD, like asthma or something?
Yeah, it could be COPD patients. And even if old COPD patients complains on the short breath, you should pay much attention because it's quite often pulmonary emboly in old patients with COPD. It could be the both diagnosis, and chronic obstruction could become acute, and it could be the pneumonia or some sputum that obstruct the airways or that's stuck between the vocal cord, and you will see the abnormal sounds. Here you can try to apply the Heimlich maneuver first, and if you see that there is not the obstruction with some piece, and you hear the sounds from in the inhale and exhale, you should take this patient to the angiography. You should suspect the pulmonary emboly here. And the COPD would be like a background. If the patient complains on the short breath, if it was hard to breathe to this patient for many years before, and now he said that it was difficult to breathe for me, but it became worse. And these words should give you the thought about the pulmonary emboly.
Ticket 19, Professor.
So the circulation assessment.
No, number 2.
No, and number 2 is the hypoglycemia. And this is already gives you the diagnosis. You see the lower level of glucose should be 3.5. And this is hypoglycemia. You should, there is a nurse and tell you about the consciousness of this patient. So you should say if this patient is in conscious or even slightly disordered of the consciousness and he can swallow, you should give him the candies, or it's better, candies is not a good variant because he could choke it. He could provocate the choking. But you should give the tea with 5 or 7 spoons of sugar if he can drink. If he cannot drink, you should provide the intravenous infusion of the glucose solution. 40% glucose, about 30 milliliters intravenously at once. And then you will see how this patient improves right after your injection. It would be in a few minutes after the glucose infusion. So, and then you take this patient to the hospital and to measure several measurements of the blood glucose level in a few hours after the treatment.
Professor, 1.5 millimole per liter, if someone has blood glucose level this low, means I think the patient will go into seizures, like it's below 30 milligram per deciliter. So it should cause more seizures and unconsciousness, right? Like accordingly.
You know, it depends on the how many years the diabetes persists in this patient, because I know such patients that feel that seizures and they feel that the hypoglycemia begins. And if they could measure the glucose level, they will see 1.5 or 2 millimoles per liter. It's quite low, but this patient could be unconscious if there is not first year of the diabetes.
Professor, we just have 5 minutes. How can we answer all of this?
All of this question?
Yes.
No,
No,
like example, what Akash is adding, like how can we answer all of that in 5 minutes?
I wonder how it would be.
you see?
No, I'm just asking for curiosity. That's it. I think we need to just tell the treatment and that's it.
You have her email, you can just email her.
Yeah, just asking. Yeah.
So in ordinary situation of in offline exam, I wish we had 15 or 20 minutes for each of you. But now in this, in 5 minutes, we can answer only this. For example, steps of the circulation assessment. You should say the signs of circulatory disorders. And if there is a clinical question, like in low glucose level, you should say low glucose level, this is the hypoglycemia. We should give the intravenous infusion of the glucose solution, 40% into peripheral vein, 30 milliliters. And that effect would be rather quickly. So not even every patient go to the hospital after hypoglycemia. They just drink tea with sugar and they recover a little bit and go further on their ways. But it's very, very bad to this patient, such fluctuation of glucose level. So if you have a question about area assessment, you say step by step what things to look and what to do if you find some areas obstruction, and that's it.
Professor, in this case, it says less than 20.5 milliosmol, but it's still high. So should we say hyperglycemia?
Yeah, I don't know why it's written here that the blood glucose is less than 20. I think it's equal to 20. So here is a hypoglycemia. You don't know if there is a ketoacidosis or hyperosmolarity state only, but hyperglycemia, and this is a correct answer, and altered mental status, this means that this patient is rather hard to treat, would be. You should take it to the ICU, and you will provide the infusion of the balanced crystalloid solution and infusion of the insulin, slowly, continuous infusion of the insulin, not bolus, continuous infusion of the insulin for the many hours, for the 20 or more hours. And after you get this patient to the ICU, you should take the blood samples and you will see maybe electrolyte abnormalities. And quite often this patient needs potassium chloride infusion slowly with the prolonged infusion. And the main treatment is the balanced crystalloid solution infusion. So when you take the blood analysis, you will see the ketonemia. In urine, you could see ketonuria. If there is so, this is a diabetic ketoacidosis. If there is no ketones, this is a hyperglycemic hyperosmotic state. But the treatment is the same. The infusion of balanced crystalloid solution and the slow infusion of the insulin. And other symptomatic treatment, what we have. Low blood pressure, we will increase it. And the low electrolytes level of potassium, for example, you will use the potassium infusion slowly. And that's all, that's the main point.
Okay, thank you.
There's a lot of complications and we can discuss the altered mental status is very dangerous. And but the main point is the increased osmolarity of the blood. So we should decrease it slowly. And this is the main sentence in this answer.
Professor?
Yeah.
About the same question, why is it important that we have to start the fluid replacement before insulin injection?
Because the hyperglycemia starts not as sudden as hyperglycemia. It takes maybe several hours or even several days to become a hyperglycemic. The glucose level accumulates and don't drops down. And these disturbances gets worse and worse hour by hour. So the osmolarity increased slowly. And because of that, we should treat not the glucose level separately, but the osmolarity. The osmolarity is the main point because it leads to the brain damage, and the brain is the main organ in our organism. It suffers in this situation not from the high glucose, but from the high osmolarity. And how can we decrease the osmolarity? There are several ways. The quickest one is to apply the renal replacement therapy. We can use it in septic condition, for example, or in kidney insufficiency, but we cannot use it here because the quickly changes in the osmolarity state is as dangerous as hyperosmolarity or hyposmolarity separate. And danger because of we will change the brain pressure and the pressure inside the neurons. So we will alter the brain tissue, and it will lead to the complications for the whole patient's life. So we should be very careful in dealing with osmolarity. So the balanced crystalloid solutions, the isoosmolar solutions, and they will slightly and slowly dilute the blood. And we will see the increased urine output. And the osmolarity will improve slowly. We will dilute the blood with balanced crystalloid solution, with the isoosmolar solutions. So the osmolarity will decrease. And we should wait. And because the high glucose level is not so dangerous as high osmolarity, we will decrease the glucose slowly. And low glucose is not so influenced on the osmolarity like a high glucose level. That's the point. So what else to say? Don't be afraid. It's only, I think it's a rather interesting questions. In real situation, you will see from the first moments, you will see much more information from the patient. You will see the face, the skin, the temperature. If you touch the patient, you will understand if there is a perfusion impairment or not. And you will assess it simultaneously in first seconds. And when we discuss it, it takes much more time than in a particular situation in real life. So here is important that hyperglycemia leads to hyperosmolarity, and we need to treat hyperosmolarity slowly with balanced crystalloid solutions and slowly infusion of the insulin. We dilute insulin, we take 50 units of insulin and dilute it on the syringe of 50 milliliters. So 1 unit of insulin and 1 milliliter. And we check the glucose level each hour that do not lead to hypoglycemia.
Professor, and also one of the complications of therapy of hyperglycemia is cerebral edema, right?
Yeah.
And I don't understand how that is possible. Can you just explain that? How cerebral edema a complication of the therapy?
It's not complication of the therapy, it's complication of hyperosmolarity state. And it could be the complication of the therapy if we would provide the fast infusion. It could be the cerebral edema if we increase the speed of the infusion of the crystalloid solutions.
Thank you.
So you can try to write down for yourself 3-5 points on each question, what to say. It could be like headlines of your answer, because we can discuss every point for several minutes, but we haven't such time.
Professor, how much time will be given to prepare for the question?
It depends. You will be on the groups of 5 to 8 students at once. You will have 30 minutes for each group. So I'll give you, maybe some of you will be ready for the first minute, I don't know. But I'll give you maybe 5 or 7 minutes initial to think about the questions.
Okay.
And you tell me, I'm ready. So you answer. And
Okay.
other students will listen to you. But it's a pity that we have no opportunity to discuss all your answers.
Yeah, okay.
Answer one by one.
Professor,
Yeah.
the students who got the exam yesterday, they don't need to connect tomorrow, right?
For tomorrow we start for tomorrow at 9 o'clock. The first groups.
The students who got it in the practical class.
Yeah, I think some people got aftermark in their practical class yesterday.
Yeah, about 15 students.
So no need to connect for them.
Yeah, if you got the mark, I have not the list of you, but I will have your names, and I'll put the mark to you.
And excuse me, teacher, I emailed you my name because I don't have the link to tomorrow's exam. It's not read yet.
Okay, I look your emails. You know, that students who got the mark yesterday, I don't know how it will be work, this portal. It would be better if you come in your time to exam to check if there is the mark or not.
Okay, because I wasn't yesterday, so.
So
Okay.
who was yesterday and who got the mark, please enter the exam and check if there is your mark or not.
Oh, okay.
Okay,
I'm not
Professor.
sure that this system is quite good, and maybe if you not enter exact time, the computer and the system will think that you are not appeared on the exam. I don't know.
Okay, thank you. Thank you, a
Try
lot,
to
Professor.
enter and maybe just say hello, and I'll check your marks.
Okay.
So, what else? I think everything is rather easier, and this is not too much to remember. But I hope you have a lot of question concern with the practical situations, because it's really interesting, and there is a different variance in practice you will see. Now, the main point you should remember that if there is a areas obstruction, you should not try to improve the blood pressure. You should first try to solve the aortic obstruction, and step by step.
Okay.
So, what else? I wish you luck,
Thank you.
and
Thank you, Professor.
tomorrow. Don't
Thank
be
you.
afraid.
Thank you, bro.
If you have some questions,
Yeah.
Professor,
Thank you.
Sometimes the link doesn't work on the exam day. So, is there any other option if suppose the link doesn't work tomorrow for many, like some students?
if it would be some problems, you should write me down via email or via the telephone or WhatsApp, and we will find out what is it. Because the only variant for exam is the link to source. So we will try to fix it.
Okay. Thank you. Goodbye.
Thank you. Bye.
Professor,
Yeah.
when are you gonna be there tomorrow? Like, are you gonna be our examiner from 9 till 2?
I have the whole day of exams from 9 o'clock till 4 o'clock in the PM, till 16 o'clock. So you should enter on your time.
Professor, will you be the examiner for specific groups or just depending on who joins at your time?
You should try to join on your time, and I can prolongate the time for answers. For example, if you start at 12 and we enter the conference at 12, and if you will have not enough time to answer, I can leave your conference open for a while after your time is over, and we will speak, I think, and about half an hour after the ending of your conversation. I can prolongate the time, but I cannot enter earlier. I didn't try this system, but that's what my chief said to me yesterday.
Professor, did any students from Group 67 get Aftermath?
I don't know your names who got Aftermath.
I see. So tomorrow we'll know?
Yeah, I will get the list of the students with Aftermath today.
I see.
Professor, I have a question. Aftermath for students who did the offline as well? Sorry, online as well?
No, only offline.
Okay. All right. Have a good day. Bye.
Have a good day.